Welcome to presentation on lung transplantation. This presentation is hosted by the Alpha One Foundation's Global Program and the Alpha One Association of Australia. My name is Randall Plant and I am from the Alpha One Foundation. I would like to introduce you to today's presenter, Professor Gregory Snell, who is the medical head of the Alfred Hospital's Lung Transplant Service in Melbourne, Australia. Greg has nearly 30 years of lung transplant experience and his service is one of the world's largest and busiest. Go ahead, Dr. Snell.
Thank you for the opportunity to talk. My full job is in lung transplant and there's around 50,000 lung transplants ever done in the world for all indications. There's the possibility these days of doing double lungs, which is the commonest, single lungs, which can also be done for alpha-1, where you just the one lung is replaced, typically the worst one, or even lungs in combination with the heart or lungs in combination with the liver, which again is important for the alpha-1 community. And as we've got more experience, we can even start to change the size of the lungs too. We can cut down lungs and use half a lung or 1.5 lungs or two halves even. So there's various options. The broad indications for a transplant include quite a number of diseases and only about 5% are related to alpha-1 antitrypsin deficiency. But in some ways that might be good news because we get a lot of practice with all the other conditions. So that we're using lungs for the treatment of airways disease and emphysema from other causes. We're looking at pulmonary fibrosis, we're looking at cystic fibrosis, other people with infections and other people with scarring conditions. And they provide a variety of challenges. And truthfully, alpha-1's from a technical point of view at the easier end of the spectrum, which is good. The broad indications for a transplant are a patient who has poor quality of life and poor survival prospects. And I'll talk a little bit later about this, but essentially that's around 20% or so of normal lung function. The donors for transplant come from people who died typically these days in an intensive care unit. And the two main mechanisms, the most common and long-standing way of having organs available for transplantation represents someone where the brain has been permanently injured and there's no hope of recovery, and they're able to donate their organs in a reasonably controlled fashion from the intensive care unit to obviously to the operating rooms. It's also common these days to take lungs as well, where the situation is where the heart has stopped. This can be a little bit trickier to get the timing right, but is emerging as an increased source of donors for transplant, particularly lung transplant. And I think many of the units around the world will increase their activity over where they've been running in the past because of this second mechanism of donor organ availability. All of the donors are deceased, and there's great controls on determining the law and the ethics and the practicality of all of that. We obviously also have to match our donors and our recipients, and it's something that is worth commenting on specifically for lungs, because the lungs need to be the right blood group, they need to be the right size, they need to have a negative match, a negative cross match, so that the features of the antigens and antibodies of the donor and recipient don't have an immediate problem. And they need to be lungs that are going to work. And again, a lot of experience has gone in over the years, understanding what is the perfect group, and then what's the group that's ideal, not so ideal, and then what's the group that we can work with that still would be appropriate organs to transplant into somebody else. The next consideration is that we've got our donor and our recipients sort of lined up, and we need to list them on a waiting list for the right combination. We've got to match them, and as I've said, we've got to match for the size and the blood group, etc., and also the sickest person on the waiting list. And this can frustrate people sometimes because they're looking at their own circumstance, but in reality, there's the availability of certain shapes and sizes of organs is more common than others, and the matching can be a challenge. And the waiting times, depending on where you are in the world, can be months to even years. Some places in the world have a system that only the sickest is done first, and other places are able to work on their own sort of list and try and game that to get as many people transplanted as possible, sometimes choosing the harder cases, sometimes choosing the easier cases. So that does vary a little bit around the world. The next consideration about transplants are that they happen essentially when the organs are available, and we've only got 8 hours to essentially take the organs from one place to another and reimplant them. So from the time a clamp goes on in the donor's chest to the clamp being released in the recipient's chest is only 8 hours. And you can imagine that limits you in terms of the opportunities and the timing and the distance you can go. In Australia, we have big distances and we can go around 8 hours between those 2 clamping times, and that gives us about 3,000 kilometres to retrieve donors from. And again, you can imagine there's some complex logistics and planning to be able to do that in a timely fashion. It's also important to realise that this happens when it happens, that we have not unlimited time to get to these hospitals, and the stability of sometimes the donors is not great. And so this happens 24 hours a day, 7 days a week. And a potential recipient needs to be aware that they could be called in at any time with relatively little notice for a transplant. It's part of it, and it's just the time. Sometimes when you don't want it on a Christmas day or a holiday, but that's a part and parcel of the business. You don't know when it's going to happen. The transplant operations for a single lung for alpha-1 would be typically of the order of about 6 hours. If it was a double, which is the most common, then you're talking of an operation that's around 8 hours or so. The patient would come back to the intensive care unit with lots of lines and tubes, and they'd be basically monitored to ensure that everything was going right, that there was no bleeding, and that the kidneys were working, and that the lungs were working, etc. And it takes as long as it takes to get the breathing tubes out and the other tubes out. And that's typically 3 to 5 days or so in the intensive care unit, and a few weeks in the hospital. And this depends a little bit again on the local practice of the hospitals, and of course how sick the recipient is, and of course any other little challenges that occur along the way. The first months are important to get someone back on their feet and fired up and getting all your tablets right after a transplant. And there's a lot of monitoring, and wherever you are in the world, you'd be finding lots of hospital visits and lots of attention to detail getting right. But as the weeks and the months pass, everything starts to settle down, and you'd leave hospital with something like about 40 or 50% lung function, but you'd be expecting by about 6 months to a year to be up around the 100%, and even sometimes more than 100%. The alpha-1 can sometimes lead you with bigger lungs, and we can actually transplant a bigger lung into that space. And so you can be above what you're actually supposed to be, which is quite an amazing statistic. Transplants are a complicated business, and you've got tablets to take, you've got appointments to make, and things don't always go right. You would expect anywhere in the world to be achieving results that had better than an 8 or 9 out of 10 chance of surviving 1 year after the operation, and you would be expecting to be 6 out of 10 survival at 5 years, 5 out of 10 at 10 years, and so on. So it's not a perfect answer to any problem, but if you were running out of lungs and you had less than 20% function, then to be back at 100% and potentially tracking on for a very long time indeed, it's obviously quite a life-changing event. It's not that the lungs necessarily run out, it's just that sometimes you can get rejection and other infections and complications and get into trouble. But we also have people who 20 years passes and they take their tablets, nothing's gone wrong, and wonder why it wasn't done earlier. The biggest issues that we do have in the long term are with lung transplant are getting the lungs to a state that they remain stable and there are no problems with the medicines you need to keep things stable. And so rejection there can occur, and that's manifest as the lung function falling off and drifting down again, and can be really quite serious and problematic, and truthfully it's hard to treat. Other things can occur, infections, and even the medicines can contribute to troubles with the kidneys in particular. So we're always on the lookout long-term after a transplant. It's not a perfect solution, and yeah, that definitely needs to be considered in the whole discussions about timing. If we now think about alpha-1 in particular, alpha-1 antitrypsin deficiency is obviously most commonly manifest as a lung problem or a liver problem, or even the combination of the two in the one person. Most commonly, obviously, I'm seeing people from the point of view of their lungs, and typically I'm referred them when they're sitting at lung function that's around a third of normal. And there's a little bit of reserve, and we try and talk about what might happen, try and optimize what we can for the future, and push out the transplant as long as possible. We're actively needing to measure someone up for lung transplant at around the 20% of normal. It's a situation that a person needs about 10 or 12% to sit in a chair on oxygen and move at all. So there's a small margin that we need. We need people to still be on their feet heading towards a transplant. They can't be just sort of confined to a wheelchair and can't move at all. The timing, as I've said, has to also, the actual timing of an assessment for a transplant, all the detailed medical tests and things, also need to bear in mind the likely waiting time. As I've said before, the size and the blood group can determine that. So determining those things early is important to try and game how long the person needs to be considered to be on the waiting list. Tricky to match transplant recipients who's a small size and unusual blood group could take a year or more, whereas a bigger gentleman who's sick with big lungs and easy to match might actually be a lot shorter. And interestingly, that's a phenomenon that's true all around the world. We do actually see people who've got what looks like the clinical picture of alpha-1, but in fact have no known alpha-1. And I suspect you've got some cousins out there that are yet to be described that are going to be alpha-2 or beta-1 or some other deficiency of a protein that does explain other, sometimes inherited emphysema conditions that are similar. I've mentioned this translates to 5% overall of our potential lung transplant recipients. And we're often seeing people who've got a little bit of liver impairment with the alpha-1 as well. So that's that combination we're thinking about. And we have to bear this in mind when we're looking at the medicines we're going to use, when we're also considering some of the complications that can occur before and after transplant. So every patient is their own unique circumstance, and we've got to work to that to try and optimize their shape coming into the transplant and coming out the other side. When you get quite ill with lung disease, you can get high pressures in the lungs, you can get bronchiectasis, you can get scarring and infections, and all of these things need to be configured to that person's unique situation. It's also true that things add up, so that if you've started with one problem in life, which is your alpha-1, but you've added smoking, you've added your occupation, you've added some bad luck with infections, then possibly your problems manifest earlier, and we're needing to talk of a transplant earlier. And again, we have to think about all those complications as we measure someone up before a transplant and think about what's their unique situation with their body and how they'll handle the whole process. So in summary, the typical person who's suitable is someone who is between 15 and 75 years of age for an adult program, who has lung function that's around 20% predicted. They've had some hospital stays. They're walking 100 meters in one shot. They're able to get only less than half a flight of stairs. They're struggling with their activities of daily living. They may be producing sputum because they've got some infection as well. They may be having swollen ankles because the pressures are high in the lungs and there's some back pressure on the heart. That's a typical scenario as presenting to me, and then I look at all the rest of the person's problems and sort those out, and then we hopefully end up with just a set of lungs that are the problem, and we fix those. How do you actually get seen and referred for a transplant? Well, transplantation, as I said, is complicated, and you want to have exhausted all your other options to improve your lungs in the meantime. So you would typically see your general practitioner who would do his best to optimize things and understand what's going on and check your heart out and the like. You would see a chest specialist for sure, and the chest specialist would work specifically on improving any infections, any fluid retention, making sure that you were exercising, making sure that you had any osteoporosis treated and any other conditions under control. They'd be starting to talk about transplant when your lung function gets under 30% perhaps, and referring to a transplant program in the 20s and low 20s. And my first task is to look and see whether the package is as stated. We're never going to transplant the people who have different, who don't have lung problems as the only major issue. We need to be sure that we don't take just on first value that someone else says they need a transplant. We need to be sure that we've sorted them all out. So our assessments are detailed, and then typically we'd work back with the physician and the GP to let them know what we're thinking and discussing the timing. And obviously you get some people who are saying, "That's fantastic, doctor, you've told me I'm in trouble, I need a transplant tomorrow, just get on with it." And you get others at the other end who are saying, "That's very complicated, doctor, I'd prefer I waited 10 years for this." And the answer, of course, is halfway in between. A wise person thinks very carefully about their choices and gets educated on the process and puts it on adds their 2 cents worth to the discussion about whether to go sort of earlier or later for consideration of this. But of course, it could be too early or it could be too late, and it is a matter of getting it right and not making a mistake. So I think the combination of alpha-1 where the livers are transplanted as well is still a pretty rare combination to be done. There's isolated liver transplants that are done, but the combination of lung and liver for alpha-1 would be only probably less than 10 patients or so in the world, I suspect, who've actually had that specific need for that. And that's good because it does mean that we're able to sort of work with one organ and beef them up, and sometimes the other organ improves as a result. So but we certainly are open to consideration of those type of problems. So if I look to the future, where are we going with these high-end sort of complicated treatments? Well, transplantation is getting better and cleverer as we get more experience. The outcomes are getting better, and we're looking both to improvement in survival and improvement in quality of life as we think of all the things that we need to optimize both before and after the transplant. So technology is helping us. One way it's helping us is the use of machines to actually support life, to bridge someone to a transplant, but also machines that can support the organs after a transplant support the organs after they've been retrieved from the donor and before they're implanted to assess them in better shape and maybe even change them and improve them to match them better to the person. And that's a very interesting concept that's taking place from Canada. We're in the throes of growing lungs off skeletons of the lung, of the collagen scar skeleton. We can now repopulate the lungs with cells and make them work. Whether we're creating a 50-year-old Volkswagen or we're creating a Porsche is yet to be seen, but we're working on that. People often ask us about stem cell treatments, and there's definitely quite an interest in stem cells in the lungs. The lungs are very easy to apply the stem cells. You can put them into the veins, and the lungs act as a sort of a filter, and they get clogged in that, and the stem cells will sit there. And also you can use nebulizers to put the stem cells in. So although stem cells were started most interest in hematological diseases and heart problems, I think you'll hear more about stem cells in the lungs as well. Now, whether the stem cells can somehow contribute to increasing alpha-1 levels is yet to be seen. I haven't mentioned, of course, that alpha-1 is a protein that's made by the liver and yet affects the lungs. So in truth, in replacing the lungs, we're not replacing the engine that makes the alpha-1, but typically if the person's taken 50 years to run into troubles with their alpha-1 the first time, then a new set of lungs going in with another 50 years is not the immediate worry at present. So in summary, I think there's a lot now understood about transplant, and it is a mainstream strategy for the management of end-stage lung and liver problems. And alpha-1 is certainly something that has some specific issues that we remain interested in, and I think there's going to be even more work in the future. So watch this space. Thanks.
Thank you very much, Professor Snell. That was very interesting and informative. We learned a lot about the many facets of lung transplantation, and that's valuable information to patients, particularly to alpha-1 patients. Again, the Alpha-1 Foundation and the Alpha-1 Association of Australia are very grateful for your time in recording this video. A special thanks to Jenny Mankervis for helping to coordinate this presentation. I would like to say that if anyone has any questions or comments about Professor Snell's presentation, please contact the Alpha One Foundation or the Alpha One Association of Australia. Thank you.